This year we're presenting the Falken trial, which is a study of first-line endocrine therapy, fulvestrant 500 versus anastrozole, in patients who are hormone naive but presenting with advanced breast cancer. Indeed, yeah. That was a phase 2 trial which showed in fact that fulvestrant 500 gave you longer disease control, time to progression, and in a second analysis showed a significant improvement also in survival. And so that led to the Falken trial, which is the phase 3 trial which people felt was required to make it practice changing. It did, yes. The confirmed trial showed in the second line setting that 500 was better than 250. And remember, 250 had previously been shown in the same population to be the same as an AI. So the 250 and the AI were the same in second line, but the 500 again showed an improvement in time to progression and in survival. And then you're right, in the first line setting, phase 2, the first study showed a significant difference in time to progression and survival. And in fact, that was the first time, this is the first time ever, that an endocrine agent, fulvestrant 500, had been shown to give a better time to progression and an improved overall survival significantly in both the second and the first line setting. So the Falken trial was therefore following up in both of those. I think Falken, first of all, it confirms the primary endpoint, which was that the fulvestrant 500 would give you an improvement in disease control. And so I think that in the basis of the previous work that you mentioned, this actually, for me, would change the standard of care for a backbone endocrine therapy. I think we've shown now that there is an endocrine agent which is more efficacious than a third generation aromatase inhibitor, and that's now fulvestrant 500. And so I think that what that would mean, if you're going to use a monotherapy, then I think monoendocrine therapy, then personally I think that should be fulvestrant 500. I think there will be a discussion about whether you add in a growth modulating inhibitor, and I think that's something that will depend on the individual aspects of the patient. You know, the performance status, the type of tumour they have, is it low or high risk of responding to endocrine therapy. So I think that's going to be a discussion. But I think that, as I say, if you're deciding what is the best endocrine therapy to use in the first line setting, then I think the data shows that fulvestrant 500 is better now than the third generation AI. What we saw with tamoxifen in the adjuvant setting was a 50% reduction in recurrence. What we saw with the AIs on top of that in the adjuvant setting was a 20% benefit from tamoxifen. In the advanced setting, we never did tamoxifen versus nothing, so we start with tamoxifen. But again, in the advanced setting, you saw a 20% benefit in terms of the AI over tamoxifen. Now we're seeing another 20% benefit for Faslodex over the AIs. So it's a similar level of improvement, size of improvement, between the SERD, the fulvestrant 500 versus the AI, as we saw between the AI versus tamoxifen. And that was certainly enough to change practice from tamoxifen to an AI. And so I think it's going to be enough to change practice between the AI and fulvestrant 500. Well, I think that we know that fulvestrant 500 does not degrade the receptor completely. Talking of its mechanism of action, it degrades the receptor. And we know it degrades it more than other endocrine agents, but it doesn't get rid of it completely. And there are other companies who are now looking for more potent SERDs. And so I think in terms of endocrine agents, that's probably the primary focus at the moment, is a more potent SERD. That will take time, a few years, but I think that is one of the main focuses. In terms of addition, combinations, then I think that's a much more wider discussion, because there's clearly people who are looking at new mTOR inhibitors, new PI3 kinase, CDK6s. We're about to see some further data on ribociclib coming here. And then there's other CDKs coming out, CDK7s, etc. So I think that the combining therapy is much more uncertain, right, as to where that's going in the future. But I think the best options are probably for a more potent pure anti-estrogen, although there are other potentials too, such as pure antiprogestins that are being developed as well. No, I just think this has been we're now seeing a quite definite step forward in the treatment of women with breast cancer, and I think that's a really positive thing to see. 20 years ago, the average survival of a woman with metastatic disease was about 24 months. Now we're moving that beyond 2 years, and with the Falken and now the Paloma data sets, we're seeing that moving into between 4 and 5 years. And so in terms of just, potential. So I think that's a really impressive, improvement that we're seeing. We're still not curing the disease, and that should remain our ultimate goal, but we are seeing definite improvement, stepwise improvement in the care of these patients, which is good to see.